So we bust out of our seatbelts, run back there. This guy, he's kind of squished in between the two aisles, unresponsive, diaphoretic, looks terrible. It is a very small, sardine plane. And so I can barely get to him to assess him. So I basically kneel down on the ground behind him, pull up into my lap so that I can assess him better, reach out and feel for his radial, which he's just dripping with diaphoresis, even on his wrist. And I feel, okay, it's tachycardic, it is thready. Okay, but he has a pulse. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day, and might just save your patient's life. Welcome back to the Rapid Response RN podcast. On today's episode, we'll be discussing a topic that gets some mixed responses. Imagine you're 30,000 feet in the air, flying home after a long trip, snuggled up with your comfy neck pillow and snacking on your airline pretzels, when all of a sudden you hear, "Attention passengers, there's a passenger who's in need of medical assistance. If there are any medical professionals on this flight that'd be willing to assist, please come to aisle 25. Well, this actually happened to me just a few weeks ago, and I have learned so much from that experience that I can't wait to share with you all. After I returned home from said flight, I actually posted about my experience with an in-flight medical emergency on social media, and I discovered another online educator has also assisted with in-flight medical emergencies, and I want you to hear her stories and insights as well. So I'm joined today by Alex, who is a paramedic with a wealth of real-world experience responding to in-flight medical emergencies. So Alex, welcome to the podcast.
Thank you, Sarah. I'm so glad to be here.
Yes, I'm stoked to finally be doing a podcast together. So one of those emergencies that Alex found herself in was actually involving her own sister on an international flight of all types of flights. So this is a deeply personal layer being added to the insights that she's bringing today. I'm excited for you to hear her stories, unpack together what healthcare providers need to know before stepping up to help a stranger or a loved one on an in-flight emergency. So today we're talking about what's actually in the medical kit on the plane, also the ethical and legal kind of gray areas of providing care in the air. We're going to dive into critical and often overlooked insights and intersection of emergency medicine and air travel. So let's dive into it. Alex, to begin, will you just introduce yourself? Why did you get into healthcare in the first place? And what are you doing these days as a medic and an educator?
Well, I'll start from the top going backwards. So I'm currently primarily in EMS education. I'm a continuing education provider. Haven't been out in the field on an ambulance in several years due to a pretty life-altering back injury that I had, but I'm extremely grateful that I was able to pivot my career into primarily education. So I still feel, EMS adjacent, if you will. But The only patients I touch these days are on flights when somebody has some sort of emergency. And I stayed licensed for that reason. Not for that reason, but I stayed licensed to continue educating and work at a college and whatnot. But I got into the field of EMS right out of high school over 20 years ago. I think we're going on year 23, maybe 24. And I spent 15 years on an ambulance and loved it. Why I got into it, honestly, I think I was a bit nosy. I was a very curious child. I was obsessed with ambulances and, coming across accidents. And I never really carried that into adulthood. And then one day somebody, right as I was graduating high school, said, "You should become an EMT." And my first response, you're going to love this, was, "Women do that?" I graduated in 2003. And my response was, "Women do that?"
Oh man, now what would you say to young Alex if she had said that to you?
Right? And I guess now I'm calling myself out. I guess it's 22 years. I just lose track of time, honestly. Like I have not, especially after 2020. So all that to say, I found out women do in fact become EMTs, and I became one, and was one for several years, became a medic, and, became an educator shortly after that. And so a lot of my even current interests are driven by pure curiosity. And going back to my sister's first, we've had two now, in-flight medical emergencies. The first one was such a mess, and she was in very serious condition, that I did a deep dive to find everything I could out about what should have happened. Nothing went well. It was like a Murphy's Law kind of thing. And so that's what led me to knowing as much as that I do about in-flight medical emergencies.
Gotcha. So it's something that your own experience drove your deep dive into researching what you got to know. I think that's the case with many things that I've become an expert in. Like I said, I was nosy, and this insatiable need to understand has driven me to deep dive and become an expert in things that maybe weren't particularly part of my training as a nurse or for you as an EMT, because things are just different in the air, right? Okay, so going back to that first one, can you just walk me through your first in-flight emergency that you responded to? What's going through your mind? What went over the speaker? What went down? You said Murphy's Law. It was just a hot mess. Put us right there.
So the first one that I had was with my sister, and we were flying overseas. We were flying to Lebanon to visit our father, visit our family. And this was back in 2019. And we took a red eye out of LAX. We are connecting and staying for a couple of days. We're staying in Paris. We're on our way to Paris. We're over the Atlantic. It's middle of the night. We've been on the flight for a few hours. My niece and nephew were 8 years old at this time, and it took a while to get them down, as well as every other child on this flight. And we're finally asleep. And right as I'm finally drifting off to sleep, my brother-in-law, because he's in front of me, it's my sister, my nephew, my brother-in-law, and it's myself and my niece right behind them. And he turns around, he taps me, and he goes, "Hey, your sister's doing that thing again." I knew exactly what he meant, because my sister she doesn't have a history of diabetes, but she has a history of hypoglycemia that's just kind of never really been addressed. It's just always been one of those things that she reports after the fact. As a kid, she passed out a few times. We'd have to give her sugar, make sure that she ate kind of thing, but it never fully got addressed. And the last time that she had a hypoglycemic episode was when she was pregnant with the twins. So it had been 8 years. And that time, I remember I actually took her blood sugar, and she was 32. And she was like walkie-talkie, like able to take food. Like she wasn't feeling well by any means, but she was able to follow commands, do all the stuff. And so she took, and we were able to get her sugar up that time. So needless to say, it hadn't happened in 8 years. All of a sudden it was happening again, but this time she was out cold. She was pale. She was diaphoretic. There was no waking her up, but she still had some muscle tone to her. She wasn't completely flaccid. It was almost like she didn't want to respond, but she was not talking to us. So we were on an airline that's no longer in business. They were called France XL. My sister had told me we were flying Air France. It was not Air France. And we got to the airport. We kept pushing the button for a flight attendant to come. Nobody came for about 10 or 15 minutes.
Oh, gosh.
That's what I remember. Let's call that family time. Okay. So while my brother-in-law is walking up and down the aisles trying to find somebody, finally found their sleeping quarters and came back with somebody. So I guess the button wasn't working. It was broken. So they didn't hear us call them. He goes and finds somebody in the sleeping quarters. As I'm trying to wake up my sister, looking around for something I can put in her mouth that she's not going to choke on. I don't have anything. And he finally brings somebody back. So we'll just say, for the sake of conservative timing, that was maybe a few minutes later. They don't speak English. My flight attendant didn't speak English enough for me to communicate, this is a medical emergency. Maybe I wasn't really explaining it well enough, but there was a language barrier there. We were speaking very broken English to one another. And I'm trying to explain, I need snacks. I need juice. So she goes, "Oh, okay." So I follow her to the area where they have all the snacks, and she tells me it's going to be $8. And I'm like, "Okay, here's my credit card. Declined. Here's another credit card. Declined." Every credit card is declined. Now, really, at this point, I should have just walked away with it and been like, "Sorry," but I'm still trying to play catch up on what's going on, because my sister has never been this ill. And my best guess is that this is a hypoglycemic episode, because I'd seen her before, but never to this degree. And what am I going to do? We're over the Atlantic Ocean. I don't know that there's a medical kit. I know we can't do anything about whatever's going on with her. So I've got all that racing through my mind. Anyways, long story long, I end up I'm going to take this. I'm going to go there. And I end up taking I put sugar in the little packet of juice, and I take a spoon, and I literally do this with orange juice for about 2 hours to my sister so that I can get the orange juice between her lip and her gums. And she finally starts coming around. 2 hours later. And it was a slow, like she's showing a little bit of signs of life, but she's finally waking up about 2 hours later. And she's like, it's my sugar. And I'm like, I figured that out.
Yeah.
So now she's taking bites of bread and I'm able to get her, but she's nauseated on top of that. And so by the time we landed, she's telling me like, I could hear you, but you sounded really far away. I couldn't answer you. And she looks wrecked by the time we landed. She just looks ill, but she's walking herself. She's able to talk. She's able to do that. And her sugar was probably still low, and her nausea was really high. So we got her some Zofran, got her some food, and she recovered. And we hadn't had anything happen like that since then until a couple of weeks ago as well. So that's where our stories kind of intersect and experiences with it. But I will tell you that as a result of what happened in 2019, I did a deep dive. And when I found out there was a complete, it's an FAA regulation to have a medical kit, which includes, I could have started an IV on her. I could have given her D50. I could have given her Zofran. I could have given her so much relief, but I didn't even know to ask for it. And the flight attendants, they saw her. I think they just thought she was sleeping or something. And I don't want to completely blame it on them. It might have been my fault not really expressing like, hey, this needs, I had a tendency to underreact to be honest with you, and kind of stay too cool when I probably needed to get a little crazy with them.
They needed to see your agitation a little bit to get their attention. Yeah.
They didn't have any because I thought I just need some snacks and I can turn this around kind of thing. But that's what ultimately led to my deep dive. And then as I started traveling more and more for work, going to conferences and trainings and whatnot, the opportunities to get up and help started happening more frequently. And I felt more confident, I think, to actually respond.
Yeah. Well, knowing what you have on hand definitely increases your confidence with okay, I can do something about this. If you just don't even know what you're allowed to do, what you have access to, I can see why people maybe not even raise their hand and be like, no, someone else should probably do this besides me.
Yeah.
Hindsight is the best teacher for sure. So I would love to use this opportunity to tell my experience as well, because I feel like they're similar with regards to lacking communication with the flight attendant, except mine spoke English just fine. Okay, so I'm flying home from a conference in Utah. I actually was speaking about how to respond to zero warning emergencies. How do you manage yourself when you have no preparation for an emergency? And so we're flying home. Me and my friend Kat, who's our newest rapid responders on the team, a CVICU background. We see this guy walking back to his chair from the bathroom, and he just has that look, it, just a little bit not right, kind of clammy. He just looks ill. And I remember nudging Kat, oh my God, look at that guy. He looks rough. She's like, oh yeah, he looks terrible. Should we go talk to him? I was like, what are we going to say? Excuse me, sir, you look like crap and we're nurses. What are we going to say to this guy?
You should get that checked out.
Yeah, we should probably look into that. Anyways, maybe 10 minutes later, we're sitting there and we hear the classic overhead, are there any medical providers willing to help? He was in aisle 25, we're in 22, so right in front of him. So we bust out of our seatbelts, run back there. And I'm used to responding to emergencies. I can handle whatever emergency. Usually it's in a bed, but I can handle it, right? This guy, he's kind of squished in between the two aisles, unresponsive, diaphoretic, looks even more like shit than he did 10 minutes ago when I saw him ambulating. Looks terrible. His shoulders are squished up because he can't even fit between the two aisles. It is a very small, sardine plane. And so I can barely get to him to assess him. So I basically kneel down on the ground behind him, pull up into my lap so that I can assess him better, reach out and feel for his radial, which he's just dripping with diaphoresis, even on his wrist. And I feel, okay, it's tachycardic, it is thready. Okay, but he has a pulse, right? At this point, he kind of wakes up and looks up at me. I'm asking a question, sir, you have any chest pain, any shortness of breath? How are you feeling? He just keeps saying, no chest pain, no shortness of breath. I feel lightheaded and dizzy, and I've been vomiting all day. I feel terrible, but I can see you, I hear you. There's no chest. He got reassured, there's no chest pain. And so he's like, I really got to go to the bathroom. I was like, I don't know about that, sir. You just passed out. We should probably wait here for a minute. So I looked to the flight attendant. Okay, now he's awake. He's talking to me, right? I looked to the flight attendant. I was like, ma'am, do we have a medical kit? Could I start an IV on him? Could I have some IV fluids? And she is just in fight, flight, or freeze, more freeze mode at this point. No, I don't have anything like that for you. No, I had nothing like that. Do you want me to call ground control? And I was like, no, we don't need to call ground control. But there's nothing medical. You don't have any. we have an AED. And I was like, I don't need an AED. The guy's talking to me, but you don't have any medical, the first aid, nothing in this flight? She's like, no. I was like, okay, so if we have no medical supplies, I'm just going to bolus this guy with his own volume. So you 3 rows back and you 3 rows back, grab his legs and lift him up in the air. And you, here's a fan this poor guy because he is just like dripping in diaphoresis. It is hot as hell. Knelt down in the aisle, right? So I'll have someone fanning. I have someone like dampening a washcloth and like putting on his forehead, and then his legs are in the air. And I reach and I feel his radio. Okay, it's like slowing down and his pulse is getting stronger. I was like, okay, this worked pretty good. He is responding to fluid challenge. He's doing much better. And then I see him just like pink up in front of me. His diaphoresis resolves. He says, I'm feeling so much better. I was like, okay, great. Crisis averted. He's like, I really had to go to the bathrooms. Okay. We're going to go real slow. So slowly lower his legs. Okay, wait for a minute. Okay, we're going to slowly sit up. Oh no, he just syncopizes right back into my arms. Like, okay, and back down. Legs up, legs up. We're not standing up again. I'm sorry. This guy doesn't have the volume to handle it. He ends up puking. So we're like turning him on his side so he can puke. Like, it's just, and I'm just cradling this guy the whole time, right? Like, oh God, please let me get sick from this random person. Anyways, I asked once again, probably 3 more times, are you sure there's no medical supplies on this flight? And the flight attendant's like, no, but if you want, I can call ground control. She goes, do I need to land the plane? I was like, no, don't land the plane. This guy's awake and talking to me now. He just needs to lay down. I'm like, we're not stating him. We are flying the rest of the way home in this position. And she kept saying, no. Do you want to talk to ground control? I was like, not really. Like, what are they going to do? Like, no, it's fine. Anyways, hindsight is 2020. So we ended up not grounding the plane. We had like 20 minutes left until our flight reached our destination. So I just kind of sat in the aisle with him and we landed. And then once we did, the paramedics met us on the tarmac and just like scooped him up and took him off the plane. And he was good.
Yeah.
Okay. Then this is kind of fun. So after they landed, they took I call him my patient, my fellow passenger off the plane. Me and Kat kind of like stand up to, go back to our seats. And the whole plane just erupts with applause. Like, oh, great job, ladies. It's really sweet to see like different people coming together to help this guy, to support us, and then like people holding his legs and fanning him. Like, it was definitely a team effort from the
it always is.
Place.
Yeah.
Yeah, it was really cool to see. So then afterwards, I let everyone deplane, and I went to the other flight attendant, the one that was not in freak out mode, that was stuck back there with me, the one in the front of the flight. And I was like, hey, so you guys are telling me there is no medical equipment on this flight? Like nothing at all, just the AED? She goes, oh, no, we have this medical kit right here. And she like opens one of the compartments and she's like, here, this big old pack. And I was like, why could I not have had this? Literally, the second ingredient is IV fluids. That's exactly what this guy needed. Why could I not have that? She goes, oh, you can have it. We just had to call ground control to get clearance to give it to you. Okay, that would have been really nice to know, to have been communicated to me. I asked specifically for IV fluids several times, and no one said anything about, let me call ground control and get clearance. They just said, would you like me to call ground control? To which our response is like, no, what are they going to do from down there? Like, I got him. Like, he's awake. He's talking to me. But in hindsight, like, okay, I'm sure they have to, like, give a doctor's order, quote unquote, for me to give fluids to someone. They don't want some like random volunteer to just be rummaging through a medical kit, not knowing what they're doing. I kind of get it now. But at the time, it was just, there was poor communication between the two of us. I didn't know what to ask for. I didn't know what I had access to. I wish I had known, because I would have said, yes, let me talk to ground control so that I have access to the medical kit. I actually have my nursing license memorized, so I could just spout it out, like what it is, and just prove that I'm a nurse. Whatever, hindsight's the best teacher. Okay. All that being said, I would love to talk through what you actually do have access to on flights. Do you know off the top of your head, I mean, obviously it's different for every flight, but like what is minimum required for each flight?
We know there's a list of like 25 items where you could get by with doing quite a few different things. What I will say, because I don't want to forget to say it later, is that many people don't realize 2 things when it comes to volunteering. One of them, which I've pieced together in this last few weeks of deep diving, since my sister's last one, since chatting with you, is that number one, you're never making the decision alone. So people have this tendency to think that, if I assist, I have to decide, because we're used to, at least paramedics are used to being the highest level of medical authority. I don't know if doctors feel that complex when they get asked to assist, or, being the only provider as a nurse coming up, like it does not all fall on you. It's actually between, like, you are the eyes of the physician on the ground. You're the eyes and ears and the hands of the physician on the ground. And really it's between them and the pilot. They decide, not you. Mm-hmm. And so that feels, and they might take your opinion into consideration, but the weight of that decision And turning around a flight of, hundreds of people is not going to fall on you. Second is that I didn't realize this because I've never run into this problem before, is that with the exception of not knowing I had access to a kit and not knowing how to ask for it, was that it sounds like she was following an algorithm. That she had to ask you if you wanted to call medical control, and then you had to say yes, and then medical control had to say yes. Because if they called medical control, they would have wanted proof of your license, which is why it's a good idea. If you're willing to assist, you have to be prepared to hand over your license or some sort of proof of it. And then at that point, it unlocks your access to that kit because it is advanced procedures. And I can imagine the liability that happens if someone wants to pretend play doctor. Or someone like me who has a PhD and is like, I'm a doctor. No, you're not. Right? No, I don't think they would. Right. But you know what I mean? They have to confirm that somebody with a medical license is assisting. And I can understand the hesitation with that. But at the same time, it's not your job to know that they just have to say yes, that you just have to say yes to speaking to ground control.
Right. Right.
That didn't get communicated very well.
Yeah, so the takeaway is Sarah's lesson learned was yes. Next time I'll say, yes, please, let me talk to ground control so I can tell them what I am seeing and what I am feeling. I have a 60-ish male who's diaphoretic and pale and thready pulses, tachycardic, but he is responding to me, right? That's what I have. And then let them decide, is this something we have to ground the plane for? Is this something that's worth opening the medical kit? And the answer is yes. And let them kind of make that decision. But yes, you're the eyes and ears because you're literally the only one that can see this patient, not the doctor on the ground.
Yeah.
So yes, hindsight. Okay, let me read. I took a picture of the kit from my flight. Let me just read it off. I'm sure it's different everywhere, but this is what mine had. 3 IV catheters. So I hope you're good because you only got 3. An 18, a 20, and a 22. 2 pairs of gloves, IV tubing with Weiss-like connectors, 2 alcohol prep pads, trauma shears, a 500cc bag of saline, multiple syringes, tape, a tourniquet, Tylenol, aspirin, atropine, something just called bronchodilator. I'm assuming that's albuterol. Dextrose, diphenhydramine, hydroxyzine, epinephrine, 2 different concentrations, lidocaine, nitroglycerin, Narcan, oropharyngeal airway, something called a CPR resuscitator. I'm assuming that's like BVM. I don't know. And a one-way CPR resuscitator, and a blood pressure cuff and a stethoscope. What about you? What have you heard are in flights?
That sounds about right. There is a FAA list of things that are supposed to be required. However, I've heard so many variables from people's experiences that I'm not quite sure if it's actually a deviation or an inconsistency, I should say. I'm not quite sure if it's an inconsistency of the medical kit itself or having access to it. 'Cause so many people are like, oh, I only had an AED. I only had oxygen. It's like, was that the case or did you not get clearance from the flight attendant to give you the rest of it? So that's what I'm very unclear about.
Yeah. And then also just want to say, there's the option of crowdsourcing too. Like Kat, who was with me, she was like, does anyone have any Zofran? Does anyone have a blood pressure cuff? Anyone have a glucometer? And we were able to gather supplies to help treat him that were not given to us by the flight attendant, just from other random passengers that were willing to offer up their items.
Ironically, the glucometer was not one of the items that's required, but they give you the dextrose and the IV stuff to give it to them. So you kind of have to just guess. By the second time this happened to my sister, I knew it was sugar related. I knew it was her blood sugar, but I found that to be really funny. But yes, you can absolutely outsource that and see if anybody else has a glucometer on them.
Yeah, for sure. This flight did not have a glucometer. From the research I've done, most flights don't carry one just because of like the recertification of the flight attendants and the little cartridges that expire. It's just like too much work to keep one. And so rather than checking the blood sugar, they're like, just treat it. Like if you think it's low, just treat it as if it's low. What's the worst it's going to do? Give you a high blood sugar for a couple hours, no big deal. So yeah, there's not usually a glucometer on the plane. Okay, so your first flight was a hot mess. There's a language barrier. It was overnight. So your card was declined. It's funny now. I'm sure it was not funny at the time, but it is a little funny now. You're like trying to save a life and they're like, sorry, your car's declined multiple times.
I was like, really?
Okay, tell me about your next medical emergency. How did it go better? How did your insights after your deep dive research help you the next time around?
Everything since then has run really smoothly. I've either had the medical kit pulled out, ready to go with the doctor on the line right away. So sometimes I think that if I'm correcting my assumption. I think sometimes maybe even the flight attendant calls the ground control and then they bring it out, because I've never had to ask for it. It's just always there. But I have talked to medical control, and most of them have been nausea, vomiting, near syncopal episode. That was one memorable one where she never really, that one was memorable because that was one of the ones that she actually was transported off the flight from, like she still needed to be transported once we got there. So we were able to help her out, do some interventions for her, get her stabilized, at least for the rest of the flight.
Can we talk a little bit about like the legal / ethical aspects of responding to in-flight emergencies?
Yeah, that's also something that makes people pause, which I think is a great idea. And my recommendation is, as a blanket statement, nothing is without risk. Even when you go to work, it is not without risk. You are not without some sort of consequence for a misstep or a misaction, and you have to be doing things with good intention. And there is a specific Good Samaritan law for this. And some people said, oh, well, that varies from state to state. And that's not actually true, because anything after TSA falls under federal territory. Now, how that applies to international, I don't know. But the Good Samaritan law protects you from acts and acts of omission. So if you decide to volunteer, or you don't decide to volunteer at all, or you start helping and you're like, I don't feel comfortable with this, that can't be held against you the way this is written.
Right. So the summary of the Good Samaritan Act is, as long as you're acting within what would be considered prudent, like if someone is maybe lethargic and you give them some fluids or some dextrose, no problem. Now, if you're like giving someone epinephrine, that might be a little bit extreme. But for the most part, you're going to have medical guidance who's also giving you information and saying you should probably give this dose of epinephrine. We should try this. So again, you're not alone. So don't be afraid of being by yourself. And like you said, you can't get in trouble or sued for acts of omission, or even for things that you've done, as long as you're not, just going cowboy and using whatever you want from the pack inappropriately. As long as it kind of makes sense for the symptoms the patient's having, you're covered there.
Yes, exactly.
Can you talk a little bit about what if you are maybe under the influence during your flight? You had a little Ativan, or maybe you had a little couple wines to prepare for your flight. What are the implications of helping out in that state?
And that's a great question, because that actually came up recently. And at the end of the day, the way it's written is that people who volunteer to assist should not, keyword should not be under the influence of any substances that impair their judgment. It doesn't say shall. Shall would be, there is absolutely no way. And so what I think, there's a lot of gray area for a reason, because you have to weigh the risk versus gain. If you have been, let's say, having one or two drinks, it's actually, you have to really be trying to tie one on the plane. A lot of people who get really blitzed on planes is because they were pre-gaming in the terminal, because the flight attendants aren't supposed to be bringing out, they're not slinging drinks like they're a bartender. It's like one or two that you get, right? And so like, let's say somebody has like one or two drinks, that shouldn't keep them from performing a potentially life-saving move, so that somebody, it's like kind of like it's risk versus gain. Like if there's nobody else there and you're the one person who knows how to do CPR, a drink shouldn't impair you from doing that, but everybody's different, right? And so that's where I think the acts of omission come in to protect you. Is like, just because you're a licensed provider that could help doesn't mean you have to help. And so generally speaking, it's not a good idea. If you've been drinking, don't help. That being said, it's going to be a personal decision. You have to decide, how capable am I? Like 1 drink, 2 drinks, I'm still capable enough. And most of the time, honestly, they just need a Zofran. They need their blood pressure checked. They don't always need like ALS interventions. And so that's not what going up there. And if nobody else is available to help, then you're probably the best person to do it. And I would honestly say that the more I drank, like the longer the flight was, the less likely I am to assist. That's just going to be my personal thing. I know what my limits are. And if you're not someone that does know yours, then that's something you need to take in consideration. And also, you might just pause. You might just pause and see if anybody else jumps up first, and then just kind of, hang back and see if there's anything you can assist with. But there's no obligation to assist. This conversation is really designed to demystify the experience so people know what to expect after that call comes out, and then make decisions based on what their ability is. I mean, here's the other thing too, is I might still be licensed. I keep up with my continuing education. I feel competent enough in my skills to be able to assist. But if I came up against something that was in my scope, but not in my personal ability to perform, then I think a lot of humility also. And having humility and having self-awareness for what your abilities are in that moment need to take precedence over everything.
Absolutely. And, like you said, it is a personal decision, but you can also weigh out, okay, so what's better, Alex with one drink on board or the flight attendant who's in freak out mode that's never, ever had a medical emergency? Like, what's better for this person? Obviously, it's your own personal decision, but I think if it was my family member, I would take Alex with 1 or 2 drinks on board over the flight attendant. That would have been my personal preference.
Right. And if anybody's done like actual, like let's say CPR needs to be done, man, you sweat, like you'll be sober in no time. It's kind of sobering too. And this is completely unrelated, but we had a drowning happen on a resort that we were staying at in Thailand. And when I tell you there wasn't a sober person in sight, we, pulled him, started doing CPR. And I mean, even those of us that didn't immediately do CPR, like it was sobering very quickly. So, all things to keep in mind. And honestly, drunk us was the best chance to survival for this guy at the time. Like none of us hesitated to jump in and help this guy when we could have easily pulled no. It's a risk versus gain. And you have to have some common sense and you have to be willing to take that risk.
Yeah. All right. I think, did we cover all the things we wanted to talk about when it comes to like the legal, ethical aspects of it?
I have a question I want to ask you, and this is not one that I've brought up recently, but we did talk about it in the past. How do you feel about the gifts that are offered by the airline after assisting with an in-flight medical emergency? Because oftentimes they will, and I've heard this from not just myself, but a number of anecdotes of people who have assisted, they move you to first class. They send you a couple $100 voucher. They put some points in your membership account. What's your take on that?
So let me start by saying I can see both sides.
Mm-hmm.
So do you deserve points? Yes. Do you deserve first class? Sure. I think that's a great idea. I personally would have a hard time just accepting it for this reason. The whole Good Samaritan law protects people who are volunteering. And what if ever this comes back and there is some sort of legal case and they said, well, you accepted compensation from the flight company. Now, granted, it's not considered compensation just to up your, ticket to first class or to, it's not monetary if it's just like points, but, a couple $100 as a gift card, even that is kind of considered compensation. And so I don't know where the gray meets. I don't know where that actually falls, but like, how badly do I really need a couple 100 points? Like, how badly do I really need to fly in first class? Not that bad. I'd probably decline, honestly. No one has offered it to me yet for the flight that I just came on, but I think at this point, if they did, I would just say, thank you so much. But I didn't do it for the points. I didn't do it for the first class. I did it because the guy looked terrible and my nurse's heart wanted to help him. And so that's why I did it. I knew what I was risking. I knew he had been vomiting. Like, I knew that he was diaphoretic and, I knew what I was up against and I chose to take that risk, not because I thought I was going to get some payment out of it in the future. So again, for people that have accepted those, I don't think it's a bad thing. Go for it. You do deserve it. Absolutely. Me personally, I don't know after all the research that I've done if I would take it.
I can't recommend taking it. And at the same time, I have received gifts. It wasn't an act of, hey, we want to give this to you. Please accept this. And I accepted it. I just got an email a few days later with a thank you. And here's a $200 credit to your account. Have I returned those gifts? No, I have not. Has it always been monetary? No. Has it always been? It's typically one of those things that in the aftermath, they do that. Here's the thing I want to make very clear. There is a specific Good Samaritan law for aviation, and it's called the Aviation Medical Assistant Act that was implemented in 1988. So if someone wants to look that up, that is specific to that. The areas of gray, the wanting to reward you or thank you for your service, right? All of that is designed to keep people wanting to assist, to make people feel safe to assist, to give people wiggle room within their scope of practice and the equipment that's available on scene. It's all designed to make the passengers feel safer flying. Because here's the thing, if you don't step up, which is fine, you don't have to, but if you don't step up, it's going to be the flight attendant and the pilot that have to intervene. And I have heard anecdotes about pilots giving IM injections because the medical ground control said, you're my hands, ears, and eyes on this. Here's what you're going to do. And they did it. And it was a paramedic / nurse whose brother was a pilot and gave me this information. So it's one of those things that they're going to do the best that they can with what they have for the passenger. And I don't think it could get any riskier than that, honestly, having a layperson intervene with medical equipment, right?
Wow. There are other countries where it is expected that if you are a medical provider and you see an in-flight emergency, that you are actually mandated by your licensing board to step in.
Is that true?
Yeah. France is one that I saw. A couple Middle Eastern countries, that's the case. But in the U.S. and Canada, it is not the expectation. If you feel like you are out of your scope, you are maybe slightly intoxicated, or you just don't want to be a part of this, you do not have to. But there are other countries and accrediting bodies who do expect that of medical personnel. So because of that, flights like American Airlines and Delta and all these national flight companies, they do offer these perks and bonuses to help inspire people to step up because they do not have to. They do not have to. But in other countries, you are expected to do that. Yeah, so the research I did, at least in the U.S., all flight attendants have to be CPR and basic first aid trained. However, we've been to those classes. We know how adequately prepared you actually are. There's definitely some great CPR classes out there that really can validate your competency. There's also some that are just like a money racket, and they just say, come on, step right up, sign the paper, and you're recertified, and you haven't actually done compressions on anybody in years and years and years. So I can't actually verify or validate the quality of the training of these flight attendants. Some of them may be stellar, but you just never know what you're going to get when it comes to flights. Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode. I wanted to add one more thing about responding to emergencies in flight. We are so used to having monitoring capability. I can just put any patient on the monitor, even just like a pulse ox, and see quickly what their vital signs are. But in flight, usually you're pretty much using your fingertips to determine your patient's perfusion, to determine their blood pressure, their heart rate. Yes, there is a blood pressure cuff on the flight. However, I'm just thinking back to how tight it was, how hard it would have been to have taken his blood pressure in the space that we were trying to respond to him in. The other thing is they kept offering the AED. And I was like, okay, maybe I'll take it. And then maybe I can put it on the monitor and see what's going on. No. It's not a monitor defibrillator. It's just some pads that you attach to a device, and the device tells you shock or no shock. There is no monitoring capability on these AEDs. They are not that fancy. So just keeping that in mind whenever you respond to emergencies, that it's not all up to you. You are basically just using your skill set to assess, to communicate with the ground team as to what to do next.
Yeah. And here's another item that you can outsource if you don't already have it on you. And I use this on my sister as well, was your Apple Watch. And sometimes at least get you one lead. And so my sister, and I should probably have opened with this, as my sister's given me full permission to tell her story because of the education that's come from it. But she also has a history of some AFib that's happened in the past. And so that was my second guess of what was happening with her because of especially she had the upper lip sweat that's cardiac. Usually a red flag for some sort of cardiac event. And she was, normal sinus. But yeah, that's interesting you brought up the AED and its lack of, ability to monitor, because have you heard about the case that happened with the couple that was going to Hawaii for their honeymoon? It was a physician actually and her husband. They were going to Hawaii for their honeymoon and she had a medical event.
Okay.
So the crazy part about that, so she's, on her way to her honeymoon, I guess they're on a red eye, and all of a sudden she has a medical event and they call for somebody to help, and an ER PA comes up and she offers to help. And I guess they're trying to help her out. They're trying to assess her. And I guess she was so unstable and she had a heart rate of 220. And I don't know all the details that went into the decisions to make this, but, as I'm referring to the fact that anything after TSA is a little bit of the last frontier for, cowboy medicine, they ended up defibrillating her.
Woo.
That's what they decided. So it comes down to this kind of risk versus gain. And they ended up defibrillating her. And it wasn't the decision that the PA made. It was a decision that ground medical control made of go ahead and place the pads and defibrillate her, because they felt that was going to be when they weighed out the risk versus gain, it was either we defibrillate her now and hope that resets her heart with whatever's going on because she was declining, or we wait until she goes into a cardiac arrest. And I guess she had said, I feel myself fading. I read in an article, she said, I feel myself fading. And the flight attendant brought the AED and, they're talking to the doctor. She's like, I don't think I can use this for what it needs to be used. It didn't have cardioversion capabilities, but they sent it and she stabilized.
Wow.
I don't know if I could do that. I'll be honest. I like to think I would, but I don't know. That takes some courage.
Yeah. I mean, have I cardioverted an awake person before and said, I'm so sorry, but I can't get a blood pressure reading on you? And yes, I have done that before, but I had a monitor. So I knew what the rhythm was. I could see the effects of my intervention. To just kind of blindly press the shock button on the AED, hoping that it does more help than harm, hoping there's no RNT phenomenon with that defibrillation, because there's no cardioversion option. Yeah, that's definitely a tough spot to be in. But again, the PA didn't make that decision on their own. They have ground control kind of guiding them, saying this is what needs to happen next.
Yeah. And I guess she responded by screaming, which she thought, was a good sign. Okay, she's still alive.
Yeah.
But yeah, that's so that just goes to show. I mean, there's so much adapting and overcoming that happens. And, I've heard of a baby being born in flight and people, taking shoelaces to clamp off the umbilical cord. And I mean, you talk about, you really have to think outside the box. You have to be prepared to be resourceful.
Yeah. And crowdsourcing, who's got some shoelaces they can give up? Does anybody have any? So, friend, can we get some? Yes, absolutely. I did want to just read out some statistics about what kind of emergencies actually happen in flight. So most common is syncope or near syncope, 37.4%, according to JAMA Network, is syncope. Which that makes sense, right? People are maybe not eating well, drinking well because they're rushed to their flight, or had a little bit too much alcohol, or not slept well, or their medication regimen's off, or there's so many things that could lead to syncope. Mm-hmm. Syncope is the most common thing you might encounter. We all know what to do for that, right? Put the legs up, which is what I did for this patient/passenger, and it actually, what do you know, helped him. However, not all syncope is vasovagal. Not all syncope is from a preload problem. Some syncope is a cardiac in nature, and you would have to do some more digging and question out to get to the bottom of that one. Okay, next on the list would be respiratory symptoms. Also not surprising, because when you're 30,000 feet in the air, the cabin is pressurized. You actually have less oxygen than you do at the ground level. And so respiratory symptoms, especially people who have pre-existing respiratory conditions, can be exacerbated in flight. That's about 12%. Next is nausea and vomiting, coming in at 9.5%. Also makes sense. People get motion sickness. They didn't eat well. All they've had today is wine and airline pretzels. Yeah, puking is kind of par for the course. So I'm responding to that. The medical kit that I had actually did have antiemetic that I could have given this person. Next in the list of frequency would be cardiac symptoms, like chest pain, things like that, not cardiac arrest. So that's about 7.7%. Seizures coming in at 5.8%. Seizures is a tough one. Most medical kits do not have any benzos at all because it's a controlled substance. That makes sense.
Yeah.
And so maybe we're digging through the patient's back to find what they have on hand. Maybe someone's willing to, offer up what they have on hand. But yeah, seizures is one that's kind of difficult to treat in flight. Most seizures, as we know, resolve on their own. If this person's having a seizure, I'm going to put them in a safety position, make sure that they have the seizure safely, monitor them, and then they're going to come back to us. They'll have a post-ictal period, they'll be okay. The seizures that we want to land this flight for are the ones where they keep reoccurring. The post-ictal period is barely lost and they seize again. Like that's the ones that, okay, we need to get dispatched as soon as it has opinions. Yeah, exactly.
I have a funny story about that if you want me to tell it right now.
Yeah, please do.
Okay, so my fiance is also a licensed paramedic. He reluctantly stays licensed. He's not in the field at all. He's in emergency management now, but I forced him to continue keeping his license and keep up with his continuing ed. And he's on a flight. And he texts me. He goes, "Oh, I just got to go play paramedic." And he was feeling like proud of himself. And I was like, "Oh, really? What happened?" He goes, "The guy was having a seizure." And I said, "What'd you do for him?" He goes, "Well, nothing, because by the time I got up there, he stopped shaking." And I said, "Okay." And he's like telling me some stuff. And I was like, "Babe, did he have a postictal stage?" And he goes, "No." And I'm like, he might want to follow up with a cardiologist because that does not sound like, did he have a history of seizures? He's like, "No, that was really weird. He didn't have a history of seizures." I'm like, you might want to keep a close eye on him and tell him to go follow up with a cardiologist, because the first thing that went through my mind was he went into an arrhythmia.
Yep.
So he wanted up to him and he asked him a few more questions and told him, "Hey, maybe go check this out and tell this exact thing to your cardiologist when you do." So.
Right. Yeah. And if you didn't see the seizure yourself, just some layperson's describing jerk motions, oh, yeah, that could be cardiac all day long. So definitely doing some further investigations. All right. So speaking of, the final thing that could happen on a flight, it's the most rare, actually, is going to be cardiac arrest. It's 0.3% of the in-flight emergencies are cardiac arrest. So you may get to bust out your ALS skills and your ALS meds, but it is unlikely. Most likely, you're going to have someone who's syncopized, and we can handle that, no problem. And like I said, sometimes babies are bored. That would be like my dream, actually, is to be able to catch a baby in flight. As long as the baby did well, then I would love it. If the baby came out blue and was not changing from blue, that would be like my worst nightmare. But catching a baby that's pink, bring it on. That sounds wonderful and exciting. Yeah, so those are the most common things that could happen on the flight. As far as what equipment is there, we already kind of read out what was there for our in-flight emergencies. It actually is dependent from flight to flight. Different companies have different medical kits. It was only recently that Narcan was added to the medical kit. It didn't used to be a stager, but now it's kind of in every single kit. And then the last thing I wanted to go through as far as data goes.
Do not expect an automatic blood pressure. Expect a manual. They have manual blood pressure cuffs. And that scares a lot of people. Yeah. And if you're not used to taking a manual blood pressure in a loud environment, because I think a lot of people forget, airplanes are so loud. That ambient noise, it is so hard to talk to the passenger who needs help if they're speaking very softly. And that can be a barrier to care as well.
Right. And they're not going to give you a Littman Cardiology 4. They're going to give you disposable,
came out of a cardboard box.
Yes. Yeah. Like some dingy little stethoscope that could be a children's toy. And that's what you have to listen to the blood pressure with. Yeah. So don't expect to have something fancy there. Okay. So that being in mind, is there anything that you now travel with, knowing what you do and don't have for in-flight emergencies?
I don't, actually, because I'm a little superstitious and I'm like, well, if I carry this, then I'm going to need it. Right. But on top of that, honestly, I have faith in the equipment that they have. I've seen the equipment that flies, at least with Delta anyways. And I have a lot of faith in the equipment that will be available to me when I get there. I would say I always had my medic license with me, but since it does get checked, I keep that in mind when I travel. I'm like, okay, I already keep it in my wallet, but I know that will be necessary if I wanted to help.
Right.
But no, for me, no. What about you?
I've done lots of reflecting because I'm definitely the nerd that wants to be prepared for everything. Like I wear a fanny pack around the hospital so I can be prepared. It's a little excessive. I recognize that, but I really love the feeling of whipping out what I need in an emergency. My car has like a medical kit. Like I'm ready for it. I've been carrying a fanny pack with medical supplies since I was like 6 years old. As soon as I knew that Band-Aids could help people, I've been carrying it with me. Okay. So I think in the future, I'm going to fly with a pulse oximeter minimum.
Okay.
Knowing that there should be a blood pressure cuff and a stethoscope on the flight. And do I really need it? Like my fingers can tell me if the blood pressure is right. I don't have an exact number, but at least I can feel, do they have a blood pressure or not? Like there's so much data we can assess without the typical tools we're used to having. What I can't assess is pulse oximetry. Obviously I can check perfusion, but I cannot tell how well someone is oxygenating to precision without a pulse ox. But that's a tiny thing that I can easily pack in my carry-on, not taking up too much space. I will not be bringing my full medical kit because I know the flight has a lot of what I need. And honestly, most things I can think of are going to be in that kit. I just have to know to ask for it and to ask to speak with ground control to get clearance to get the thing. And then, I forgot to mention, there's gloves too. So if you're like, oh my gosh, this person is puking, there are gloves.
Well, even the flight attendants have their own gloves when they're collecting trash a lot of times. And they're like the black gloves. They're pretty good.
Okay.
I've seen those. They're not like, they're like lunch lady. Yeah. They're not
No, I mentioned, yes, they have their own gloves.
Mhm.
They did not need them to me.
Yeah.
The gloves I ended up getting, because this guy was puking, when they handed me the AED, it was an AED packaged with like one of those mouth-to-mouth resuscitators. So not a BBM, just like the little mask seal. You can put your mouth over top of it.
Yeah,
one of those.
it's a mouth barrier.
Mouth barrier. Yeah, one of those things. And then there were 2 pairs of gloves. So I gave one to Kat and I had the other one. And there was no other gloves that were offered up to us. But yeah, good point. Okay. So flying next time, I'll bring a pulse oximeter. And then I actually have my nursing license number memorized. But if I didn't have that memorized, I would just make sure it was saved somewhere easily accessible on my phone or somewhere where I could easily get to it and spout it out to ground control to prove that I do have the skill set to help with this person.
Yeah, because that would be the worst thing, is to be willing to help, able to help, and then they won't let you help because you don't have the ability to prove who you are.
Right. All right. The final thing I want to talk about is documentation. It's drilled into our heads to document. If it's not documented, it didn't happen. Okay. What are like the ramifications of our expectations of documentation when it comes to in-flight emergencies?
To my knowledge, I know that the flight attendants have to make a report, and I'm sure ground medical control has to make a report. It's like calling in. So those who work pre-hospitally, it's like calling in base hospital and you're giving a report. So it's kind of like that, and you're taking orders and that kind of stuff. So they have their own paperwork that they do. I'm not under the impression that there's any paperwork that we do as the person helping.
That's my understanding as well. After the flight was over, they just got me and Kat's first and last name. And like, they just said, oh, so you're nurses? I said, yes. Like, what kind? I was like, RN, like registered nurse? Like, okay, that's literally all they asked us. And then as far as documentation, I didn't have to write anything, fill anything out. But I did want to I took basically like a voice recording on my phone just to remind me the details of the event in case something ever comes of it.
That's probably very smart to do.
Just in case. Just so I can like have a clear recollection of what happened. Rather than just like, oh, yeah, it's been 5 years ago. I don't remember. Just so I can have something to refer back to in the future. But I ended up following up with the patient/passenger, and he actually is doing very well and was very grateful for the assistance that me and Kat provided to him. So I got to have follow-up, but I don't think follow-up is usually part of it. Usually you might get an email saying, thanks so much, but there's no actually details of how that person did after the flight, after they were, taken off by the paramedics on the ground.
Can I be honest about something I did?
Sure.
I was so curious how my patient was after the fact that I totally creeped. I internet sleuthed them, and I saw them posting stories, and I was like, okay, they're good. Like, they recovered, they lived, they're fine. But I was so curious. But yeah, you get zero follow-up whatsoever on them.
Yeah. All right. Is there anything else that, for the sake of thoroughness, that we need to make sure my listeners know about in-flight emergencies so they're ready for their next one?
I would say it is a very infrequent occurrence to even have to be asked to help.
1 in 600 flights is the statistic, actually.
Yeah. And I would say I'm on a plane at least twice a month, maybe more. Sometimes it's, last month it was 7 flights. So,
oh gosh.
And my sister was the only one. She's my hazard. And I made her eat before that flight too. And she still bottomed out. But she was not completely unresponsive. And Air France was absolutely incredible. So we just gave her a lot of orange juice and she came around. But all that said, I would say it doesn't happen very frequently. I would say anybody that works in any type of emergency medicine that can adapt and overcome is going to be advantageous. And it's like getting on scene where there's multiple, we didn't really talk about when there's multiple people helping, and you kind of have to learn to be cohesive, and one person kind of takes the lead. And it's the same as like when you get on scene of a call and you've got fire and EMS there, or you bring in somebody to the ER, or you as a rapid response going to the ICU for something. It's cohesion. And so work together, communicate with each other and say, hey, what do you think about this?
Yeah, absolutely. It's definitely a team sport, this whole life-saving thing. And so knowing the people that are working alongside you to help, fortunately, I know Kat very well, so we were a great team.
Yeah.
But yeah, if I was with some random person I never met, how are we going to divvy up the task? We're going to position ourselves in proximity to this patient because this is a very tight space. Who's best at which role? Okay, you're pre-hospital, you're the one getting the line. You're used to getting lines on a bumpy ambulance. You are up for IVs. And I will start drawing up medications. Like, how can we divvy up tasks appropriately, knowing what our skill set and our background is? And all that stuff is something to keep in mind for sure.
Yeah, definitely. Like, I had delegated blood pressure to somebody that looked at me and was like, I'm not the best person for this. It was the funniest thing. I was like, oh, I'm sorry. It was a physician of some subspecialty of ortho. And I was like, no problem. I got you. So if you're going to divvy up skills, like the first thing is to say, are you comfortable getting this? Are you comfortable getting my line? Are you comfortable getting a blood pressure? And then go from there.
Yeah, absolutely. Well, Alex, thank you so much for sharing, like, not just your knowledge, but being vulnerable to describe like how helpless it feels when you don't have the resources you're used to having at your fingertips in our normal role for healthcare. Responding to an in-flight emergency is one of those like rare moments where our training kind of meets the unknown, where, like you say, you got to cowboy up and like figure it out. What do you say? Like the Wild West, tying shoestrings around umbilical cords, and yes, all that stuff. I've loved hearing how you've navigated. Also, the stories that people have shared with you, share with me, especially your story involving a loved one. That's like next level, having to focus and dial into your skills. It's a powerful reminder of how human this work really is, in and out of the hospital.
It really is. And I appreciate your enthusiasm to inform your listeners about the mysteries of this. There isn't a whole lot of information. Nobody ever talks about it. And we just kind of figure it out as we go.
Yeah. Yeah. And it's all the things that I wish I had listened to 2 weeks ago before I got on the flight. Like, where was this podcast for me 2 weeks before I flew? So I hope it empowers the people. So if you are a healthcare professional, I hope this episode gave you something valuable to think about, to prepare yourself for next flight that you have, knowing like what is in the medical kit and understanding the policies and preparing not just like mentally, but also physically how to respond with limited resources, with limited space, with limited support, but knowing that your knowledge and your skills can make a real difference. So I've so enjoyed this conversation with you. So in closing, Alex, I know people are going to want to hear more from you. Let me just start by saying you need to follow Alex on social media. Alex, can you just tell people, like, what are all of your social media handles? How can they find you? What else are you offering in the world these days?
So you can find me on Emergency Resilience on all the major platforms. I'm the most active on Instagram, mostly in the stories. I like to run a lot of polls, ask a lot of questions. And then there is a huge highlight reel on my profile, my Instagram profile. It's titled IME, so In-Flight Medical Emergencies. And there's about 100 stories compiled from over the last few years that I have just put research, put links, all the things, and people's anecdotes, people's testimonies of helping out in flight. They can find it there. If you go to my website, emergencyresilience.com, you can take some very fun continuing education courses that I offer, anything from death notifications to CPR-induced consciousness. There will be one coming out on ketamine therapy and, eventually one on in-flight medical emergencies, because I think it's one that'll be fun. This should be CE worthy, right? It's education.
Absolutely. Alex, thank you so much for your time today. Everyone, until next time, stay grounded, stay curious. And if you ever find yourself in row 22 and hear that request for your expertise, I hope now you will feel confident and know what to do. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.